Top Med Talk. It's Monty Mython here, Editor-in-Chief of Top Med Talk with another journal club. Now this week I've chosen yet another article from Anesthesiology and yet another article from Dan Sessler and colleagues. This one is about triple low alerts do not reduce mortality. It's a real-time randomized trial. It's published in January's Anesthesiology, that's 2019, 130, pages 72 to 82. Say again, the title is Triple Low Alerts Do Not Reduce Mortality. Now I'm going to pick off 3 papers in this journal club. I'm going to first go through the details of this paper, the real-time randomized trial, and then point to 2 separate articles about nudging physicians to do things. And I hope that will make sense once I've gone through the main paper. So we've all heard of triple low now, this idea that intraoperative hypotension, a low bispectral index, or BIS, and low minimum alveolar concentration, or MAC fractions, have been associated with mortality in patients undergoing anesthesia for major surgery and worse outcomes. Unsurprisingly, the combination of any 2 low values, and especially the combination of 3 together, are associated with even worse outcomes. And as the article points out, that's been covered off in a relatively recent meta-analysis that you can find within the citations in the paper. It's reference number 10. So, triple low events. We've identified the challenge. That's either a MAP less than 75, a bispectral index of less than 45, or a minimum alveolar fraction, a MAC, less than 0.8. They're associated with bad outcomes, and the belief is they may be causal. So in other words, if they happen, if you got the blood pressure up and or turned the anesthetic agent down, things should get better. So this particular study tested the hypothesis that providing triple low alerts automatically using the electronic health record system to clinicians would reduce 90-day mortality. So the group studied patients having non-cardiac surgery with volatile anesthesia and bispectral index monitoring. They were electronically screened for triple low events. So when a triple low event happened, the clinicians were randomized to either receive an alert or to not receive an alert. If they were randomized to receive an alert, the alert would say, consider hemodynamic support. The patients were blinded to the treatment. Helpful responses to triple low events were defined by administration of a vasopressor within 5 minutes, or a 20% reduction in the end-tidal volatile anesthetic concentration within 15 minutes. So, triple low happens, or an element of a triple low happens. This alerts the system automatically. Randomized, half clinicians get a warning badge that comes up, whoop, whoop, consider hemodynamic support. The other half don't get the alert. A helpful response is give vasopressor or turn down anesthetic agent. So of the qualifying patients, that was 7,569, of 36,670 patients, i.e. 20% of the total screened cohort, 20% of them had triple low events, and they were randomized. All 7,569 were included in the primary analysis. 90-day mortality was 8.3% in the alert group and 7.3% in the non-alert group. Clinical responses were helpful in about half of the patients in each group, with 51% of alert patients and 47% of non-alert patients receiving vasopressors or having anesthetics lowered after the start of a triple low, and that was statistically significant. But there was no relationship between the response to triple low events and adjusted 90-day mortality. So what's the conclusion from that? Well, it's 2 big messages. Real-time alerts to triple low events did not lead to a reduction in 90-day mortality, and there were fewer responses to alerts than expected. So you'd kind of hope that if the computer pinged and said, consider doing something about the hemodynamics, and you believed that triple low was bad, that you'd have a very high response rate to it. The other thing was that there was similar mortality with and without responses. So whether they were in the alert group or the non-alert group, if they did respond, those responses did not seem to have an impact on subsequent outcomes. So the conclusion is that there's no strong relationship between responses to triple low events and mortality. The editor's perspective on that, the triple low events, although still predicting mortality, did not appear to be causally related. So if the clinicians acted on it, whether in the alert group or the non-alert group, that didn't seem to affect outcome. Now I'm going to play you an interview with Dr. Dan Cole, the past president of the American Society of Anesthesiology, talking about triple O and the fact that it's difficult to tease apart this association and causation, and the science behind of this is still all a little bit uncertain.
Well, I think, if I could be a little scientific here, I think we need to put that data into context.
Okay.
It's associative data. It's not necessarily causation.
Yep.
I think the triple low, there are some things within at least two of those lows that we commonly try to avoid.
Yes.
The other low, the low anesthetic requirement, may actually be a surrogate or an indicator of the patient's mental reserve. So I think those are important parameters that can help identify somebody at higher risk for postoperative delirium, cognitive dysfunction. But the extent to which, if you get one or two of those that is a little bit off and it's going to be perfectly predictive of postoperative delirium cognitive dysfunction in a causation fashion has yet to be established.
And as I was just looking at a paper we're going to be doing in Journal Club for another one of the papers from the Cleveland Clinic with Dan Sessler and Andrea Kurz about I just had a quick read of it. As far as I could see, the automatically flagging up triple low issues. And two disappointments, it seemed, from the paper. One is that most people ignored the information, so they carried on anyway. And those who responded to the information, and I apologise if I've got this slightly wrong, but I'll go into greater detail later on, is those who did respond to it successfully, it didn't seem to make a difference. So the causality is still, the greyness is still there, but perhaps everyone would agree with the hypotension one. I think you probably don't want to leave them. And there's some other people have some rule of thumbs about age and MAP there, which is a bit like your 60 and the Versed thing. Don't let the MAP go below your age, which is not a bad rule of thumb. I'm getting nervous now as an old man. So there you have it from Dan Cole himself, not only the past president of the American Society of Anesthesiologists, but also one of the initiators of the ASA Perioperative Brain Health Initiative. So there we have, recognising the challenges with trying to separate associations with cause and effect, and I think it's still a known unknown as to whether doing anything about triple low events is going to make a difference to outcome, although many of us think that in particular pursuing the hemodynamics and how you might make the blood pressure go up is still sort of ripe territory for further investigations. Personally less convinced about the depth of anesthesia, as Dr. Cole referred to. Maybe being more susceptible to an anaesthetic is a manifestation of your brain state, putting it very crudely, and or how inflamed you are at the time, because they're all interrelated. I'm going to move you on to two other articles about nudging physicians. The first one is by David Lebarski and colleagues, also published in Anesthesiology 2019, same volume 130, pages 154 to 170. Worth a read. As always, David's very challenging. His colleagues joining in there. Why money alone can't, in brackets, parentheses, always nudge physicians. The role of behavioural economics in the design of physician incentives. Then I've also added into the show notes. I'm not going to get into the details of that. If you're into understanding about nudges and what might make us be more responsive to alerts, please do have a read. I put all the links in there in the show notes. The other one is in the New England Journal of Medicine. It's beyond nudges when improving health calls for greater assertiveness. It's from Ubel, PA, from Duke University Medical Center, and Rosenthal, published in the New England Journal of Medicine 2019. That's in the January edition, 380, pages 309 to 311. Now, this is, aside from just anesthesia, this is taking a much broader look at when improving healthcare calls for greater assertiveness. It goes through how you get different behavior changes. So there's a particular figure in there, the continuum of strategies for influencing behavior, that at one end of the spectrum goes from doing nothing or monitor behavior through to the idea of eliminating choice. Now, the spectrum from eliminating choice goes through restrict choice, change choice, through architecture, guide choice using monetary incentives, persuade using social incentives, provide information, or back to do nothing. Very challenging article. Again, it gets into the fact that, perhaps financial nudges or penalties are required, and what level of nudge or penalty or incentive might be required to make a difference. Right towards the end, they make a quite challenging conclusion, but I think we might all be getting into this space recognising that if electronic nudges of triple low doesn't have an impact on one of the world's finest medical centres, really to behaviour, then maybe you have to find different ways of encouraging clinicians to do the right thing. So their final paragraph says, when nudges fail, or when there are serious societal consequences associated with suboptimal behaviours, we believe health and healthcare decision makers should consider going beyond nudges and adopting more forceful policies that maximise the chances of changing health-related behaviours. And indeed, within the text of the article, they go into the idea of actually giving a salary bonus or withholding salary, or having two different pay packets. One is your base salary and the other one is a well done for doing the right thing pay packet. So I hope you've enjoyed Journal Club. Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram. Or we can even gawp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find Top Med Talk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on Top Med Talk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out edpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EdPom meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So EdPom, ebpom.org/meetings. Get yourself on there, and why not check out the Dallas Masters course, Perioperative Care Practicum. Hopefully I'll see you there.